Good morning, distinguished colleagues, and thank you very much for selecting our session today in the morning. Our short but very informative session would be devoted to atherosclerosis in younger patients. And today we are welcoming Asiyat Aliyeva from St. Petersburg, who leads the dyslipidemia unit ward and the senior fellow of the Laboratory of Lipid Disorders, Professor Yezhov, Chazov Cardiology Center. And the most important, that he's also director and the president of Russian Society to Study Atherosclerosis. No, this is you, Igor, director. Oh, yes, he's the president. Absolutely, absolutely. He's the president and I am the director. And we immediately start our session. First, Asiyat will tell us how to examine younger patients on dyslipidemia. Then Professor Yezhov will speak about hypercholesterolemia, and I will speak about the familial cases, familial hypercholesterolemia, and what should be the level of LDL. And then we will be happy to answer your question. Asiyat, you're welcome. Dear Igor, dear colleagues, good morning and good afternoon for some of you. As our timing is very pressed, so let me go immediately to the presentation. Today it's a day two of the Congress, and I would like to express gratitude for the invitation and for the fantastic event. Well, this is quite challenging task. Today, very briefly and very informative, I should tell you how to examine younger patients on dyslipidemia. Here you see I have no conflict of interest in this presentation. And colleagues, preparing to this meeting and analyzing literature, analyzing PubMed database, I found lots of publications in the recent years, especially that is devoted to the results of the populational study on the prevalence of dyslipidemia, to study the prognosis in severe dyslipidemia patients. So this is very relevant. This is very relevant. Today we are looking at the need to early treatment of younger patients with dyslipidemia in the position for search of optimal start of dyslipidemia. And today we will speak about the scales, SCORE2. But in fact, both scales allows us to assess high risk of 10-year fatal and non-fatal cardiovascular events. And if you refer to the clinical guidelines, and today mainly the presentation would be made with the basis of European and American clinical guidelines. So clinical guidelines offer us active effect, medical treatment in the situation when 10-year risk of a fatal and non-fatal cardiovascular events is very high. But is it really justified position? Don't we have to start earlier? So these are still quite open questions. And probably we'll speak about the need in the future. These positions are not yet shown in the clinical guidelines. Probably in the future, we will come to the early interventions due to the concept of the cumulative type of atherosclerosis, which speaks about the importance not only LDL lipoproteins today, but also importance of duration of expositions LDL. But I'm sure, dear colleagues, that today we have practitioners with us, and that is why we want to have very informative session. What is the current position on dyslipidemia screening, on the management of such patients? So clinical guidelines on cardiovascular prevention, 2021, a very clear scheme. We go from the assessment of cardiovascular risk, moving to the selection of personalized treatment. Not so simple. Clinical guidelines. We identify graphs, diabetic patients, elderly patients, and we never select a separate category of younger patients. We spoke a lot that SCORE2 came to our clinical practice and for the assessment of 10-year risk of fatal and non-fatal cardiovascular events, we now use SCORE2, which is offering us parameter of non-LDL cholesterol instead of total cholesterol, which was offered in the SCORE scale. But probably it would be interesting to ask a question here. We see here that SCORE2 starts from the age limit 40 years. But today we speak about the younger patients and definitely even about the early age. So we come back to the recommendations of cardiovascular prevention. So we will see that the tactics of decision-making depends on what category of risk our patient belongs to in score 2. Is it all? Have we answered all the questions about the risk of our patients if we used just score 2? Definitely not. A priori, these patients could be categorized in the high and very high risk, even if we don't use score and score 2 in the next list of the situation. And I will not talk about diabetes or chronic kidney disease. So this is a condition that in the gradation of high and very high risk could be seen in a number of clinical guidelines. Also, I will speak about familial hypercholesterolemia because there would be another presentation today that is devoted specifically to this issue, colleagues. You can appreciate it, and these are national guidelines of 2020. Big focus is done on subclinical atherosclerosis, duplex scan, and definitely, I wouldn't say carotids because you can see here that localization of the plaque is not located in this case. So atherosclerotic plaque, for example, in the basin of the femoral artery would have the same prognostical significance from the position of cardiovascular risk like plaque in the carotid artery. So I would like to draw your attention to point 1 in the category of high risk. One quite significant risk factor here, the total cholesterol higher than 8 or LDL higher than 5. Well, such patient, even younger age, automatically goes to the high cardiovascular risk and risk by score, and score 2 is not assessed. So does it mean, although today my presentation should not be devoted to the issues of treatment, but nevertheless, why do we assess the effect of dyslipidemia and why do we assess cardiovascular risks? We do it in order to make a decision whether medical treatment is needed to our younger patient or not. Colleagues, here we can appreciate in case of significant increase, LDL target is just for the patient of high risk 1.8. And the question is, which tools are we going to use? That's another story, but we have to, in such situation, we have to reach the target. Now moving along the clinical guidelines. So left part, these are recommendations on cardiovascular prevention. The right one is the lipid disorders of the European Society on Atherosclerosis. You see here that top 2 ovals here, red ovals, they in fact demonstrate the commonality of the position because we have to start from something. We immediately go deeper into subclinical atherosclerosis, but there is quite justified question from the practitioner. The basic one in the patient, when do we start the screening to dyslipidemia? So here you can appreciate that in general population, we see cutoff males older than 40, females older than 50, or in the postmenopausal period, if it comes earlier, even if we don't have information about the risk factors. Here you see that the recommendation for the lipid disorders give us the same thresholds, males older than 40 and females older than 50. So there will be very many quotations from the clinical guidelines today. Please appreciate the position. The second one, oval. Risk assessment scales are very rough ones and require particular attention to the results. That's the key information that calls us to start the risk assessment from score and score 2. But at the same time, we need to understand that this is not the equal solution. There are a number of conditions that will be later on discussed that will change our cardiovascular approaches to the risks, even for score and score 2, our younger patients goes to the mild or moderate cardiovascular risk. And one of the key positions here, recommendations in cardiovascular prevention, definitely proved here there is clear link between the level of cholesterol and progression of atherosclerosis and cardiovascular events. So in all the studies, long-term reduction of LDL is associated with the risk reduction for cardiovascular events and diseases. So proportional reduction of cardiovascular risk according to the reduction of low-density lipoprotein reduction. And finally, colleagues, position of score 2 is not applicable for patients with genetically determined lipid disorders, and it's important to remember about it. So that's brilliant consensus on rare diseases in lipidology that is called from phenotype to genotype. And it has already been published before. And definitely we are focusing on the familial hypercholesterolemia because that's most frequent lipid disorder. But colleagues, definitely it's important to remember that we have a number of other genetically determined dyslipidemias that definitely would change cardiovascular risks, would influence that. The only slide about familial hypercholesterolemia here, because I won't touch it, we know that there are scales for clinical diagnosis of familial hypercholesterolemia, the scale of Dutch lipid clinics, and I call you to use them for the correct assessment of the cardiovascular risks in our patients. If we speak about the correction for the identification of dyslipidemia, here our American colleagues probably taking one of the most aggressive positions, which with years a little bit getting milder, because you remember they had very big populational studies that had an objective to answer the question, because if we initiate treatment with statins for everyone, shall we get any advantages in the populational risk reduction? So analyzing the literature, we see that American colleagues are actively dealing with that, but nevertheless, although there is data about the obvious efficacy of statins for LDL reduction, still the application of statins in population of 20 to 49 is still a gray zone. It's still a gray zone which requires a very individualized approach. And our American colleagues are offering the big algorithm how to use the index of coronary calcium and polygenic risk scales for more precise risk certification in this very challenging category of the patients. Without diving deep into the algorithms, now I would like to say a few words that the index of coronarium calcium definitely included into the European and into the national clinical guidelines. And here you can appreciate, you can see here the chart on the thresholds of coronary calcium index, and this is how we can identify patients in the low or mid, moderate or high cardiovascular risk. Colleagues, that's probably one of the methods of choice in our younger patients where screening gives us increased level of LDL, but still we have right in decision-making about the aggressiveness of our treatment that we have to deal with. And definitely index of coronary calcium from the hypothesis of visualization has definitely increased sensitivity. And due to that, it is a visualizing test as a brilliant tool to reduce the risk. We frequently speak about the methods, and after these methods, we can go to high risks, risk increase. So this method is absolutely unique, because if the index of coronary calcium is 0, it allows us to go down, to de-escalate. So this is how we can say that the 10-year risk of cardiovascular events in our younger patients with increased level of LDL possibly is not as high as we can expect it, so we can postpone the start of treatment. It's important to mention that index of coronary calcium should be measured in statin-naive patients, those who are not yet getting hypolipidemic treatment, and definitely due to the fact that the level of calcification will be increasing in the treatment, and the index itself will be increasing. But in the situations of the intermediate risk, in the situations when we see the increased level of LDL initially at the baseline, that could be an important tool that will help us in the decision making about the true level of risk and confident tactics of decision making. And the third and important block, colleagues, here, these are targets in modern lipidology. And I'm not speaking about triglycerides because Marat will be talking about it. I would like to say a few words about lipo-A small. Lipo-A small. According to the clinical recommendations, it is recommended at least once to everyone adult in life. And we have to talk about the brilliant consensus which was published in autumn 2022 about the role of lipo-A small in the development of cardiovascular disease of atherosclerotic genesis and the progression of aortic stenosis. Almost 1.5 million people around the world have increased level of lipo-A small, and this is cut off 50 milligram per deciliter. We can see here that each quartile of increasing lipo-A small will give us continuous increase of cardiovascular risks. That is why, of course, the assessment of genetic, because from the position of genetic predisposition, it's a factor which is extremely important for the assessment, because to a minor extent, it can be non-pharmaceutically corrected. I mean, physical exercise or changing of the lifestyle or nutrition. But there could be a question from our audience today, from our colleagues, why we are going to assess lipo-A small if today we have no tools to reduce it. We have very limited tools to reduce it. Well, our European colleagues are quite brilliant in answering that question as how we see the increasing level of cardiovascular risk, and they give the following algorithm. We see here that in the vertical axis, this is the risk score, which we assessed by SCORE and SCORE2. And horizontal level, this is lipoprotein A small. And this is exactly what we are going to talk about today. So basic scale SCORE and SCORE2, that's not it. That's not it. Even the risk is low according to this scale. So this is our young patient with dyslipidemia. But if we deal with reduction of lipo-A small, it could be in the yellow zone or in red zone, which requires more aggressive management. What could be the aggressive management? Because we can use just apheresis for that. Because if our patient is a green zone, but due to the high level of lipo-A small, it goes to the red or yellow zone. Currently, we have a position that if we correct traditional risk factors, then total cardiovascular risks could be more effectively corrected in such patients, because if we cannot influence it directly. Speaking about the national guidelines, we see here that we are quite relevant to European recommendations in cardiovascular prevention, etc. But over there were cutoffs 40-50, depending on the gender. And we recommend everyone who is 40 plus screening. That includes lipid profile assessment. Definitely the separate point, they would be HDL assessment, just to have proper understanding and use SCORE2 for the assessment of cardiovascular risk. You see the duplex scan with class 2A and the index of coronary calcium with class 2A that unfortunately is not included into the standard of reimbursement. Still important tool to clarify the cardiovascular risk, and it's also there in our clinical guidelines. And last but not least, finalizing, dear colleagues, definitely SCORE2 is a basic tool for the risk assessment. Definitely today, we will talk about the cut of 40 years when we perform dyslipidemia screening. And of course, we are paying very big attention to the familial anamnesis, lipo-A small, and exclusion of genetically determined dyslipidemias, because all this situation could significantly influence the level of cardiovascular risk and for the decision-making tactics. And wrapping up, we are happy to show you some contradictions which are still available today, because studies for Mendelian randomization demonstrate us the earlier we start correction, the better. And the earlier we correct the lipoproteins of low density, the better. But in the clinical guidelines, we nevertheless continue being quite reserved and conservative about the correction of LDL in patients with not very high cardiovascular risk. And I believe that these two positions in the future could lead us to the common denominator. Thank you very much, and I give the floor to the next speaker. Thank you very much, Asiat. Colleagues, I remind you that Q&A time would be at the end of our session, and Asiat just showed us that entering this gray zone where it is not clear whether we need or not yet initiate the treatment, we have to count many more parameters than they have just the event. And now we are happy to give the floor to Professor Yezhov, hypertriglyceridemia in younger patients. Thank you very much, Igor. Good morning and good afternoon, dear colleagues. I have no conflict of interest within this presentation. So this is cooperation with different stakeholders. Now, speaking about TG, triglycerides, the first we have to emphasize, in the population, the number of such patients is increasing with increased level of TG, particles reached with TG. But if level TG is less than 10, and that's about 28% in the population, then here most probably secondary reasons are important or polygenic origin. But in the severe hypertriglyceridemia, that means TG higher than 10, and the prevalence here is about 1%, then in this case, most probably we face with monogenic variant. The reason of growth, the reason of increase of this parameter, these are mainly cardiometabolic conditions, which is the BCMET syndrome, insulin resistance, diabetes type 2, unhealthy lifestyle. It is very clear what we are dealing with in this situation. Also thyroidal disorders, renal disorders, and uncontrollable, or let's say forced administration of different hormones. It could be female or male sex hormones or glucocorticoids, especially due to COVID syndrome. So regardless, the reasons to increase level of TG, we have a very clear link, independent link between TG and the risk of cardiovascular complications, and also all-cause mortalities, and also risk of involvement of pancreas as acute pancreatitis and even pancreonecrosis. According to the data of these larger studies, the link, I would like to emphasize that the link is very clear, even with the adjustment with the classical risk factors for alcohol intake, etc., etc. So regardless of the reasons to increase TG, the tactics is almost the same, First, to identify and to reach target levels of LDL, non-HDL, and Assiatsagirna already spoke about it, also exclude secondary reasons, and we always require sticking to the healthy lifestyle, including diet, physical exercise, smoking cessation, and also cessation from alcohol for these patients. If we do not reach main target levels and TGs are still increased, it is very clear that LDL cholesterol plays a key role and statins play a key role here. Then again, we provide further non-medical steps, and in fact, we have just two options on hyper specific therapy. This is fenofibrate and omega-3 pharmaceutical form. Experimental treatments is extremely expensive, and it is not yet fully available. Yesterday, I was not quite right showing the first slide for clinical guidelines for lipid disorders. I introduced some changes. So this is the auspice of Russian Cardiological Society as the majority guidelines related to cardiology and cardiology, nosology, and also a list of societies, professional societies. And I emphasize the importance for our Congress, National Society to Study Atherosclerosis, Eurasian Association of Therapists, Eurasian Association of Cardiologists, and Russian Medical Society of GPs. So if we speak about the International Disease Classification version 10, so for hypercholesterolemia, we have just one code, which includes familial hypercholesterolemia as well. But in case of triglycerides increase, we have 4 different codes, 78.1, which is isolated triglyceridemia, so this is mainly type 4, then 78.2, which is type 2b and 3, then 78.3, type 1 and type 5, and then reserved for familial combined hyperlipidemia, which is 78.4. So these are the diagnoses, and this is important, and then the objectives of treatment. And if for LDL and non-HDL cholesterol, it depends on the category of risk, but for triglycerides, it's all the same. The lower, the better. That means for any category of risk within 1.7, And here we demonstrate the tactics is important in the category of high and very high risk. So the baseline is statins. Then, if we have a little bit of increase of triglycerides, omega-3 could be okay, 2 grams per day, BID, and it could be escalation of the dose if needed, but most probably that would be enough. But if it's higher than 2.3, then fenofibrate in the dose 145, and it is in Russia included in the EDL list, and then if needed, then omega-3 2 grams to BID. If it's higher, we, regardless the risk category, we use combined treatment, hypertriglyceridemia treatment. According to the Russian legislation, the evidence level here shown here, and here are European levels. And I would like to emphasize that patient has no category of high risk, then statins here are not indicated. And now I would like to show you some examples. So these are younger patients. And the title here is hypertriglyceridemia in a younger patient. So that's the first case, cardiological patient that came to our clinic, Chazov clinic, aged 47. So he used to be absolutely healthy person. He was even the blood donor, but then they said it's not possible any longer because Hilo serum was found. And then for 3 years, next diagnosis, hypertension was diagnosed and diabetes type 2. And within next 7 years, his body was covered with xanthomas. The total cholesterol here was 15 millimole per liter, vitiligo idiom. So he was administered statins and he took them irregularly. He was covered with xanthomas. And what we see here is acute pancreatitis, but not to the vessels. Definitely, we examine the patients very extensively upon administration. So there is no familial history. So there is severe smoking, also moderate use of alcohol, of subcompensated diabetes, very extended xanthomatosis, and also physis of obesity. And also, we saw here not just xanthomas, but inflammation and even itching in these areas. So we performed genetic study in this case, and we found out the defects in the gene of LMNA, nucleotide replacement, exon 6. Exon 7, they identify another replacement. This is heterozygote mutation, which is typical for hypertriglyceridemia. And in this gene, we also see some features, clinical features of manifestation. So this is hypertriglyceridemia and attack to the pancreas. Besides, these patients normally develop atherosclerosis, but luckily in our patient, we did not see it, although in fact, risk factors were very low. And as I mentioned before, before the hospital stage, atorvastatin was initiated in the dose of 20 milligram, and that's the lipid level 55. In these patients, LDL is not detected and you cannot calculate, and definitely TG immediately kills you down. You kill them all, 55. So we recommended modification of the lifestyle, and to atorvastatin of 20, we added fenofibrate of 145 and 4 grams of omega-3 polyunsaturated fatty acids. And just in 3 months, we got this result. He performed the test locally. So lipidogram demonstrated a much better cholesterol, total triglycerides 8.8. Well, here you see a clinical improvement. Clinical effect is very clear. So the size is reduced of xanthomatosis. So almost minimization of features of xanthomas. And also we have to mention that it's not only for such patients, definitely it's mixed. It's a mix of secondary changes related to the increase of TG plus genetic changes. But for all the patients, as I said before, from the very beginning, according to the international guidelines and Russian guidelines, it is non-medical prevention. TGs, they are extremely sensitive to these approaches, but not for all the patients, just for particular genetic mutations. We also have many patients like this, and very rarely, these are pretty slim girls, slim ladies without risk factors, but with TG30, and they don't eat any fat, any fatty food, and also they exclude carbohydrates. But the situation is not changing. But all in all, if we speak generally for the whole cohort of patients with a high level of triglycerides, the alcohol cessation gives us very good effect. Body weight reduction is 0.1 millimole per liter per each kilo, and this is good. Also, physical exercise gives us reduction up to 20%, and in the ratio omega-3 polyunsaturated fatty acids give us reduction up to 15%. The second case, that's a female lady that referred to us at the age of 57. But please appreciate here, starting from the age of 18, hypertension, from 32 years old, diabetes type 2, and at the age of 47, very severe destructive pancreatitis that required surgery. So by that time, the total cholesterol was 18, TGs 25 millimole per liter. At the age of 49, she had MI, and then she faces again exacerbation of pancreatitis once every 2-3 months. So that's a progression of ischemic heart disease, and you see that phenotype is very different between the first and the second case. Phenotype is very different. She has statins because of increased pancreatitis and transaminases increase were stopped. So she started getting ezetimibe and fenofibrate, and by the age of 51, she actually gets 3 stents already. Although later on, she reach stabilization, remission of ischemic heart disease. So when we hospitalized and did the genetics, her mother had 2 MIs at the age of 43 and 47, 2 strokes, 54 and 57, and 57 was fatal one, and hypercholesterolemia. Well, this is from the words of the patient. Well, actually, no bad habits. HbA1c was 7.5, and also there was stenosis up to 45% in the peripheral arteries. Also, we performed genetic tests. We identified 2 mutations here, and both were related to the protein alanine. And in this position, it is quite typical mutation associated to the partial lipodystrophy hypo 2 of type 2. It is already described, and in patients we see hypertriglyceridemia, triglyceridemia and hyperlipidemia, hypertension as well, atherosclerosis. But this mutation in the global databases was not properly described and presented, and most probably this is also pathogenic version. So the difference here that in fact here the diagnosis could be not a partial lipodystrophy but generalized. That means complete lipodystrophy. And actually, what is a partial lipodystrophy, familial partial lipodystrophy? We call it the syndrome of Kibberling-Dunnigan. So in these patients, we see a redistribution of fat tissue, So there is no on the extremities, limbs, upper and lower limbs, but in the upper part, in the face, in the neck, shoulders and back, there is excessive amount of fat. So that's the example. So this is upper limb. That's the arm. You see very severe increased muscle mass. So muscle mass is developing here, although there is no fat tissue. According to the electroversis of lipids, we make the diagnosis of hyperlipidemia type 5. Please appreciate here what is dominating is pre-beta lipoproteins, and in fact, lipoproteins of very low density. So dynamics of the lipid profile. So the patient was referred to our center from Karelia, and colleagues, Dr. Korneva and Professor Vezikova, Professor Vorobyova, they refer the patient to us with these type of lipids. Triglycerides, I emphasize it once again, about 55. So apheresis of lipoproteins was initiated, and in our center it's functioning, the apheresis unit functioning from 2021 in our center, so almost for 2 years. And actually, this is absolutely for free for the patients. That means all the procedures carried out and reimbursed by the medical insurance for the patients that have clinical indications to that. And please appreciate here the positive dynamics of lipids. So complete, which is generalized, or partial lipodystrophy is very rare. In fact, it's 1 case per 1 million population. And in the Russian Federation, the first case was described by the Endocrinology Center, and this is publication in the Therapeutical Archives back in 2015, and you can refer to that. It is available in open access, and in the world, there are about 500 patients like this. And definitely, mainly patients are facing metabolic disorders. And then we see cardiovascular complications and liver involvement, kidney involvement up to the development of sepsis. So in fact, slowly and steadily, polyorganic failure is developing. That's why apheresis here is very important, is extremely important. And she continues the procedures of apheresis, regular apheresis. So there is synthetic adipokine leptin. So this is engineering, genetic engineering. It's called metrileptin, which is not available in our country, but currently patient is fighting for getting access to these treatments by the special program, according to life indications in the framework of a special program, could be reimbursed with these treatments. That's the dynamics of your lipids during the procedures, procedures of lipid filtration. So we performed already more than 30 procedures, and so we use special filters, and filter is called Everflux 5A. In order to make procedure effective, we should process 1.5 volumes of circulating plasma. So here you see level of triglycerides before the procedure. That's blue one. You see it's very varied, ups and downs, but so we see this peaks up to 50, and definitely it was related either with some mistaken measurements or acute decompensation of diabetes. But all in all, we managed to support currently here at quite good level. So TG is almost within a normal range. So effective procedure, apheresis of lipoproteins, and by the end of the procedure, the median and the rate of TG reduction is more than 60, and median is changing from procedure to procedure, actually 62%, that's TG level reduction. Here you can appreciate in a number of cases, it's more than 80%. And the most important here are the actually clinical effects, which are very important. We can see complete elimination of risk for the injury of pancreas 1 year after the start of the procedure, and the effect is still persisting during the 2nd year. So we need to emphasize that the prevalence of hypertriglyceridemia is increasing all over the world, including the Russian Federation, and it reaches 30% in the population. High level of TG is associated with increased risk of cardiovascular complications plus pancreatic complications. Hypertriglyceridemia, severe one, is developing due to genetic defects, and the spectrum of tools includes statins, fenofibrate, omega-3 polyunsaturated fatty acids, and lipoproteins apheresis. With that, thank you very much for your attention. Thank you very much. Thank you very much, Marat. So that's very interesting case. And yes, I truly believe that hypertriglyceridemia, well, we see it more and more frequently. That's true. But this is not the topic of the next presentation. And now let me give the floor to myself. And I will make 2 presentations now. And my first presentation is in fact sounds like a logical continuation of ICEAT's presentation. Do we need to reduce LDL cholesterol for the youngest if they don't have any serious risk factors? So you should agree, colleagues, that this is not a simple question, because truly very frequently they tell us what should be LDL in the youngest, and should we give them the tablets. So let's go back to PESA and PESA Health Studies. I remind you that that was the study which was published actually 2 years ago. This is Spanish work, this is Spanish publication. So that was quite a young sampling of Spanish people, and they asked them, healthy one? Yes, I'm healthy one. Do you go in for sports? You don't smoke? Yes. Mom, dad are healthy? Yes, they are healthy. And do you have any challenges, problems, stress, whatever? No problems, no problems. What are you doing now? I'm running along the sea. Okay, let's be recruited into the study. What is the study? We'll take your blood and we'll perform also ultrasound of the carotids. All right, let's do that. And they recruited patients like this, absolutely healthy. So they got very interesting situation. So in such healthy patients, young patients, relatively young patients, there were already some atherosclerotic plaques. Atherosclerotic plaques, and when you see the blue color on top here, this is involvement of the several arteries, although they were healthy, absolutely healthy volunteers, and they had no bad habits, and only one parameter could save the person from developing of atherosclerosis of carotids, or let's say leg arteries. This is LDL less than 1.6. If it's lower than that, they didn't find the plaques. If higher than that, they found the plaques. So a number of these patients had additional examinations, including MRI. And here on the left, you can appreciate that in majority of cases, they found plaques mainly in the leg arteries, 74 versus 53%. 53, these are neck arteries, carotid arteries. So low extremities arteries. Sergey and colleagues, they published the work and they showed that low extremities arteries are more prognostically important than carotids. So that's the confirmation that it is truly, we are going hand in hand. But when they checked the level of inflammation in atherosclerotic plaques and they performed PET with FDG, it appeared to be that inflammation is not always there, and this is very good. So that means the plaques are quite stable. But let me remind you, these are patients without cardiovascular disease. So, but if you take patients with diseases, the situation would be totally different. And if there was some inflammation here, we saw it more frequently in the lower extremities arteries. So this is rate of atherosclerosis identification using different methods, males and females, blue and red, so correspondingly. And you see the atherosclerosis identification rate is not so high. Only combining different tools, we can say for sure whether there is or there is no atherosclerotic plaque. So I would like to draw your attention to the lower part of this slide. You see the colorful columns. This is Framingham scale of 30-year risk. So while it's no atherosclerosis, the other colors atherosclerosis is on board, and the higher, the more sites, more segments are involved. And this is Framingham scale of 30-year risk, low risk, moderate, and high risk. So those patients who get into the high risk here, they have much bigger atherosclerotic load versus those patients who are getting into the low risk. You would say, well, probably it was very clear and very logical. Maybe it was like this, but now it is clearly proved, scientifically proved from the scientific point of view. So what does it mean to all of us? We need to make a focus on the risk and calculate the risk of one specific patient. And we know for sure that if the patient has some concomitant risk factors, for example, stress or insulin resistance or increased weight, then each should be counted by the doctor, and then doctor makes a decision whether to administer or not hypolipidemic treatment. Now, about statins. Or your statins, they make people stupid or they injure the liver. So I think scientific point of view, when we make the presentations, you have to stop discussing it. It's proved it's not like that. But there is another proof that in patients with average age, the presence of carotid asymptomatic atherosclerosis, that's a direct way to Alzheimer's disease. That's a direct way. So when your patients, or let's say children of the patients, are saying, oh, our dad cannot remember anything, please start something that improves the memory. But there is no magic tablet like this. But what we have available is a great way to prevent that. But somehow we don't use it. So the results. This is PESA study. I will formulate it myself here. So this is not direct translation. Subclinical atherosclerosis is seen in the patients of average age pretty frequently and progressing very fast. MRI and PET help to assess subclinical atherosclerosis and inflammation, whether this atherosclerosis is significant. The lower the LDL, the better. We need to search for new risk factors, lifestyle closely related to atherosclerosis, and physical exercise, weight, smoking cessation. These are the factors of success. Instrumental diagnosis could be very useful and should be used. It should be a must. And Professor Yezhov in the Cardio Center also has focused study of the carotids. So there is no need to put with the machine for quite a time, 2-3 minutes, and this is enough to say whether the patient has atherosclerosis or not. And if yes, then we can move on. And atherosclerosis, that's a reason of hypermetabolism of the brain. So they say, my dad cannot remember anything. Oh, guys, you had to deal with that before. And very interesting finding, the higher is the activity, the more is the cardiac resource. Also, we know the guides for the prevention of cardiovascular diseases. So these are healthy volunteers where we need to calculate 10-year risk. And that's targeted treatment, personalized treatment, individually for the patients and at the populational level, what we have to do. Because if we resolve it just at the level of one person, this is just to try to empty the sea with a spoon. We make an accent, what we need now. So stepwise approach to the identification of treatment focused on the smoking and the correction of risk factors. Smoking cessation. And if patient says, I'm gaining weight, yes, he's gaining, but first of all, stop smoking, limitation of alcohol, switch to Mediterranean diet, and regular physical exercise. That's important to reduce the level of cholesterol in the youngest. So the pressure should be 120, 130. And diabetes and insulin resistance should be mentioned here. So where this patient goes, the one who we are talking about, it goes to the category of lower and high risk if the age is 70 plus. So healthy patient without diagnosis, it does not mean that there is no risk at all. And we have a scheme how to provide prevention in the healthy volunteers. This is modification of risk factors. But we saw PESA study, and we understand here that the increased level of cholesterol that in the blood test would not be, let's say, blood or fat, whatever. It's important risk factor that we sometimes don't pay attention to. Score 2 is like Framingham scale, because here we see not the risk that the patient dies, but the risk that the patient would have fatal or non-fatal cardiovascular event. So to the total cholesterol, we replace not HDL, because the levels of TGs are very important in the development of atherosclerosis, and not only. In our country, patients get in the category of high and very high risk. So that's the scale if the patient is 40 plus. How do we manage them? The healthy volunteers, you know this scheme, In patients, LDL should be less than 2.6, So organizers of the Congress asking the question, so I'm answering. That's the answer. And if by score 2 is risk is higher, then it should be less than 1.8 or less than 1.4. But the question, what should be a LDL cholesterol in the healthy? Less than 2.6. So that's another scale, very useful scale, that shows the life expectancy of healthy volunteers without cardiovascular complications. So they show that the risk is reducing in every LDL reduction by 1 millimole per liter. So this is what we see. This is what we see. And the examination of statins in the primary prevention. So very fast, very fast. Because complications from here, from statin treatments, are not identical to the secondary prevention. So muscular symptoms not developed, muscular disorders, forget about it. Liver dysfunction, yes, ALT, AST could be increased with statins in the primary prevention, but definitely clinically it is not significant. Renal dysfunction, forget about it. And risk of diabetes mellitus type 2. Let me say it's very slow. Let me say it very slow, because in the primary prevention, statins do not increase risk of diabetes, even in patients with pre-diabetes. So it's a difference. Ocular injuries. Well, yes, risk of cataracts maybe is increased a little bit in case of rosuvastatin administration, but there is a theory that these patients simply survive until cataracts, and the others, they simply die and no cataracts. So possible side effects in the primary prevention cannot be compared with benefits. Risks are not compared with benefits. And we know for sure that it could be muscle pain and increase of ALT and AST, but it's very easy to resolve, which has no clinical and prognostic significance. Now, referring to the question from the organizers, the level of total cholesterol and HDL cholesterol in patients without risk factors. Let's refer to our ancestors. For example, if there is a mutation, loss of function, PCSK9 loss of function, then these patients would never have ischemic heart disease. And LDL 0.4 has no side effects. Don't be worried. They don't have Alzheimer's disease or other cognitive disorders. It's totally opposite. Anthropological data is showing that our ancestors had non-HDL, but total cholesterol 113.2. But agrarian revolution, so, and the plate and hypodynamia. So it's a reason that the population with total cholesterol is 5.56 millimole per liter. This is not normal for us cholesterol level. And there is William Roberts, who is the chief editor of American Cardiological Journal, and he's director of Baylor Cardiological and Vascular Institution. He wrote a very emotional article, and the title is very not nice. It's Cholesterol, Idiot. So what does he say? He's telling us that there is only one, the most serious effect of ischemic heart disease is cholesterol. If you have obesity or diabetes and you don't give infosports or you smoke, you will not have atherosclerosis if you have a low level of cholesterol. The optimal level of cholesterol, LDL, 1.3, 1.8, the lower the better, the lower the better. And 1.8, that's approximately 4 millimole per liter total cholesterol. Have we answered the questions from the organizers? Yes, we have. And definitely William Roberts takes this data not from somewhere, but from the studies, specifically Framingham study. It shows that ischemic heart disease is not developed in those where the total cholesterol less than 4. And wrapping up, I want to show you cholesterol level in our ancestors and also in the tribes which are currently inhabit Amazon River. And the red level at the bottom, and this is our level of cholesterol. Is it good? No, it's not good. With that, thank you very much, dear colleagues. And now let me immediately move to my second presentation. This is also my presentation about familial hypercholesterolemia. I have to say from the very beginning that this is a joint presentation. This is a work and I have to say from the very beginning that we made recommendations for the adult patients, and formally we could not put children here, but I cannot skip children because in the familial hypercholesterolemia, it would be strange. So this is genetically determined monogenic lipid disorder with mainly autosome dominant type of inheritance. Of course, we will speak about polygenic things as well. We cannot keep still. So there is heteron homozygote. Prevalence is about heterozygote 1 per 200, 250, but in Russia, it's higher, 1 per 180. Homozygote is much more rare, and this is very good. And the prevalence here is 1 per 300,000, depending on the region. Patients with familial hypercholesterolemia, according to Russian guidelines, get in the category of high risk or very high risk if it's associated with risk factors, or if it's just no risk factors, familial case, it would be the category of high risk. So here we appreciate 3 main scales of calculation. Probability of diagnosis familial hypercholesterolemia. We used Dutch criteria. Why we selected this? Because point 4 here, this is not the fact of increased LDL cholesterol, but how far it is increased. And if it's more than 8, then this is definitely a familial case. If 6 to 8, that's possible, and 3 to 5 possible, probable and possible. And it will show you the easiest calculation. And there are 3 main reasons of monogenic lipid disorder. First of all, mutation in LDLR, and we know a lot of mutations, more than 1,600, that could ruin the receptor function and cause development of familial case. Zulia yesterday presented the data on Tatarstan, and they showed that identify 160 new mutations in the LDL receptor, which is very respected. The second reason, this is mutation is ApoB, and the third gene is PCSK9, which is also very important. So when do we have to start thinking that the patient has familial hypercholesterolemia when total cholesterol is higher than 8 and LDL more than 5, and in children total more than 6.7 or 3.5 LDL? If there is early onset of atherosclerotic genesis in males younger than 55 or in females less than 60, also there are xanthomas, and well, I don't think that you can sudden case of cardiac death in the relative in the family. Treatment. Well, it's all very simple. It's a unified system of risk stratification. First of all, patients of a very high risk. So the target level less than 1.4, and we have to reduce more than 50% from the baseline. And if it's a category of high risk, less than 1.8, and doubling down from the baseline level. So what do we administer? Triple combination: statin, rosuvastatin, ezetimibe, and PCSK9 inhibitors. And speaking about children, we would like to draw your attention to this. Statins could be started from the age of 8, only in case of familial hypercholesterolemia, ezetimibe from 6 years old, and evolocumab since 10 years old. Evolocumab we cannot yet administer, but this is legal collision, and definitely it will be changed. Let me show you our calculator of cardiovascular risk, which is called ATERA-STOP. This is not just for familial hypercholesterolemia, but also for other things. We put here Dutch criteria, and you can download this calculator if you need to calculate the presence of hypercholesterolemia. You click for doctors, you choose the criteria of DLCM, and then you put this ticks on the right, and then you see the probability of familial case. Definitely, there are people who say that polygenic disorders should not be considered under the story, but still we should speak about the polygenic, because we know in some particular polygenic abnormalities we see penetration rate. And if patient tells me, well, all that, it's just trash, because I used to have cholesterol 5.5 and now it's 8. Why? I didn't do anything. I have the same nutrition. And he's looking at you. I'm telling him, well, because you used to have this polymorphine and now it works. And now it works. And now speaking about children and adolescents, it's very important in children and adolescents to identify the level of cholesterol, not to miss this disease. And if the patient has a diagnosis of familial hypercholesterolemia, and you will ask whether he or she has children, then in this case, we have some common sense component to have genetic analysis. Let's have a look. Xanthomas and lipoid arch in the the retina and xanthelasms, and definitely we give you only cold water here, so only 30% case. Don't believe that. Although I want to show you some patients with familial hypercholesterolemia. This is how they look like, and I think everybody saw that. And now crossover, we know that there is such a crossover in patients with identified mutations and non-identified mutations with familial hypercholesterolemia. This is overlap on the level of LDL cholesterol. And this is confirmed mainly by very different studies. At the same time, the level of LDL is increased with age. In case of polygenic hyperlipidemia, overlap is increasing, and only genetic diagnosis could give you the exact answer. I know, and I tell you that in our guidelines, we say that genetic diagnosis does not matter much, so we don't recommend it as a must. But with the new hyperlipidemic treatments, we probably should get back to this question later on. So why? It is difficult to identify children because xanthomas, xanthelasmas are very rarely seen. Total cholesterol and LDL increase with age, and only single measurement of the lipid profile is not always enough. DNA diagnosis is important in children younger than 16, and the earlier the better. That means when we identify familial hypercholesterolemia, already they could have quite overt atherosclerosis, and it would be good to check lipoproteins. So dark columns, this is presence of mutation, and light columns, no mutation case. And you see how increased the risk in case of mutation, one specific mutation, which is very important. And in terms of prognosis, it also matters. Although we are not calling you to do genetics tests for all of them. Left part of the slide, this is patients after acute coronary syndrome, ACS, and left columns possible, and the red one is definitive. And the right part of the slide, higher columns, these are younger patients who already had MI, and please appreciate it here. So there is higher rate of familial hypercholesterolemia, including definitive diagnosis. So there is a definition of cumulative dose of LDL cholesterol, and here it's a pretty high rate. So that means when we calculate the cumulative dose, we clearly understand that it is cumulative dose, so because you can say that 160 millimole per liter, but this is the attempt to merge together the increase of LDL cholesterol and total cholesterol, so and also the time of effect to the vascular wall. That is why our task in treatment is to put these curves of linkage with cardiovascular complications, which is age dependent for patients with familial hypercholesterolemia. And there is particular algorithm of cascade screening where definitely we should know that genetic diagnostics introduces a very big contribution in this cascade, but it's not a must to have the cascade screening. In fact, the cascade screening, well, it sounds like this and sounds very pompous, but in fact, you call the relatives of the first and the second line, and you measure cholesterol for all of them, LDL cholesterol for all of them, at least to do this. And about cascade screening, so let's refer to the Dutch study. This is 28,000 patients with familial hypercholesterolemia. 23,000 were diagnosed through the cascade screening. So that means in those who were zero patients. So the role of cascade screening is huge. It's really huge. Of course, we have options to use Simon-Broom, and this is second scale to see familial hypercholesterolemia. We see it on the slide, but we don't use it in the Russian Federation, so we are not going to the depth of that. And again, going back to the mutations, let's say that mutation for LDLR mutation, it's a classical mutation, which is 95% of the cases, ApoB mutation from 3 to 5, and PCSK9, 1%. And for the LDL RAP1 AP, that's a protein modulator, that's very rare. So mainly we talk about the mutation of LDL receptor. 5%, there are big deletions. That's very serious situation, That's very poor prognosis. then functional defects could be split into the synthesis, transport, binding, internalization, and processing. If we speak about the genes which are coding receptors. So this is genetics, but I think in this case, we also need to know that we need to know as early as possible to identify these patients and to start the treatment. And this scheme tells us that patients, if patients get into the category of a very high risk, we should immediately start from combined treatment. And if the target level is reached, we will add on PCSK9. With that, I thank you very much for your attention. And we're happy to invite everyone back to us because we have some questions here. And let's move to the Q&A part. So good morning, patient, age 32, without bad habits, overweight, total cholesterol about 8 millimole per liter. Non-medical treatment is not very resultative. What should be the tactics and how frequently to control lipids and when and how we should administer drug treatments? So Marat, can I ask you to take this question? Patient aged 32, no bad habits except being overweight, and non-medical changes are not helping. Total cholesterol is 8. What to do in this case? So that means what to administer and how frequently to control the lipids. Well, my position, not enough data. What is HDL cholesterol here? We need to know because here maybe LDL could be less than 5. And if there are no features, or no other risks, so young patient, I wouldn't administer anything. I think it should be better control, non-medical control, and dynamic follow-up. In such cases, we need to perform once in 2 years transcranial brachycephaly once a year. Next question to you, Marat. I think we have many questions. Yes, we have many questions. Yes, we have to work with that. Yes, I got it. Marat, what do you think about the use of omega-3? And immediately, please recommend whether we can administer omega-3 for pregnancy, for the whole pregnancy. Thank you very much. Well, in the guidelines, there is clear recommendation in TGs higher 1.7 or higher than 2.3. The drug has a right to be administered, but not in the noble triglycerides, so not in the 1.7. So regardless the risk category. Speaking about the treatment of pregnant, again, the drug I think should not be used here. And during the pregnancy, it could be secondary triglyceridemia. And I think nothing terrible happens only if we don't have severe risk of pancreatitis. So we manage such patients with apheresis and then actually effectively delivered. Okay, good. Okay, very good. Good. Then if we want to involve ICIAT, we want ICIAT to speak up. So there is another interesting question: hypercholesterolemia, non-familial, and IVF and hormonal treatment. It is possibly related. What should be the attitude to that, if I understand correctly? I see it. Yes, not very clearly formulated, but if we correctly interpret the question, so that's the secondary hypercholesterolemia, which was created with the hormonal replacement therapy. And when we speak about the younger patients, it is emphasized here that this is not genetically determined, not familial one. In the case of secondary dyslipidemia, when the patient is planning pregnancy, definitely here we are refraining. We assess cardiovascular risks, from medical correction. We assess definitely and we refrain from that. And then we keep in mind that during the second and in the third trimester of pregnancy, even physiologically, the level of total cholesterol is increasing. So that's potential risk zone. So we look at lipidogram in the situation when we deal with the patients with a very high risk. And if the risk is truly high, we look at apheresis treatment. But definitely, speaking about the medical treatment, we come back to that only after the discontinuation of lactation. Next question. Anifrolumab should be lifelong or particular duration of the course. So if you don't mind, I will take this question. Anifrolumab, this is monoclonal antibody designed by AstraZeneca for the treatment of systemic lupus erythematosus and coagulopathy. So this is antibody to interferon, if I'm not wrong. Please correct me if I'm wrong. And actually it gets fantastic results, but probably it's not exactly about our topic, but there is a question we'll be happy to answer. Logically, it is done during the exacerbation of this disease, normally during the exacerbation. If it's continuous exacerbation, then the injections should go lifelong. But if not, then probably short course is enough. But we are not specialists. We are not specialists here. So probably we cannot refer ourselves to rheumatologists and give full-fledged answer. Or maybe this is not question to us. Well, anyway, we will try to answer. We will answer. No problem, no problem. So next question, good morning. If patient is 33, no complaints, no bad habits, Doppler scan of carotids without pathologist, total cholesterol 657, HDL 106, DL 4.7, TG 1.5, glucose 6, glycated 5, and also overweight. I do apologize. That's equivalent to the first question, equivalent. The answer was already given. The scale Atera stop, is it relevant or not? Well, Atera stop, it's a calculator. Yes, it's relevant. It's relevant and you can use it. We should scale it up. We should scale it up. And it's important because we have some ideas how to do that. And I do hope that more and more doctors and the patients will finally use it later on. When do we have to add on isotimib to statins, colleagues? When? Well, it depends. It depends on the risk category. If it's a high risk, then you can do it stepwise, but it's a very high risk, then currently we are offering to start immediately and preferably as a fixed combination. Well, question 10. You already said that increase of transaminases, but actually we cannot see that in the statins, clinically significant, up to which level and how? But if the level is increased 10 times, so it's a reason to stop, right? Oh, and I somehow don't see the end of this question. Okay, I can read some of the questions. Yes, I will take the question. If it's more than 120 units per liter, we have to stop, then wait for the reduction and then switch to the other statin in a smaller dose in combination with ezetimibe. That's the tactics. So, well, just 3 upper levels of norm, then temporary discontinuation. Yes, that's very frequent question you are discussing, how statins influence testosterone and reproductive function in young females. Igor, that's your question. Yes, great. Well, actually, we understand that testosterone is synthesized from cholesterol with sterol synthase, so no influence. So the idea of question is clear, but no influence. Please don't think that somehow testosterone could be reduced in males and actually the function would not be working. So I can tell you that the effect of the long-term statin treatment is 1/3 of Viagra. It's proved. It's proved, really. This is just not our conclusion. You can read the literature. So definitely testosterone is not reduced. No worries. So next question, let's ask Asiya to answer. In the youngest subculture of megapolises, they use vape instead of traditional tobacco smoking. What is the attitude of experts to that in the aspects of changes of lipid disorder? Well, I would be very brief. Marat has brilliant presentation about it, about systems of tobacco heating. So problem of lipid disorders, well, here we do not see any direct correlation, replacement of one to the other, and we understand that traditional tobacco smoking is a key risk factor. We understand that complete cessation is priority, but definitely there is some data that systems of tobacco heating in some aspects, if you select in between two, so that's a smaller evil, but that's about a general cardiovascular risk, but not specific influence to the lipid disorders. Right. I don't know how all these systems could influence lipid directly, but definitely they're not bringing any benefit to the organism. So our recommendation is that we are strongly against vapes. We are strongly against vapes. So the rest of half measures and residual risk, which could be associated with any ways of deliveries of anything, whatever delivery. So all this risk is still persisting. Absolutely right. Absolutely right. So it can be stepwise discontinuation to smoke. What is the optimal level of lipid spectrum of children and adolescents? Total cholesterol of 4 and LDL2. Tactics, male, age 34, total cholesterol 6.7, LDL4. No familial case. Should be administered treatments, and if yes, which ones? Well, 34 years old, 6.7 LDL4. Well, probably not enough data. We would be happy to see carotids, but in principle, what should be the tactics of management? Well, I think it should be the same, like in the first case. We were asked, but the only thing I would like to refer to children and adolescents, because 5.3, it's not the threshold for them. They need lower level, 4.2, right? Yeah, right, absolutely. So if adults 5.3, 5 is total, and 5 and 3, yes, here we should administer statins, but it could be even higher category of risk, even very high, if we see, let's say, carotid atherosclerosis there. And if you want, you can check coronary calcium. Yes, many questions. Let's move on. How fast cholesterol could be reduced post-delivery? Well, normally cholesterol is increased up to 9 is normal in third trimester. It is reduced within several months, doesn't require any medical correction. If patient is getting azitinib and PCSK9, but still LDL is not 1.8, what should be the further tactics? Well, you can add on azitinib. You can change the dose of PCSK9, let's say alirocumab 75. Then I would make 150 or even 300. But no other way possible, except extracorporeal methods. But all depends on how much. For example, he's not reaching 1.8. For example, it's 2.0. I would say that's fine. Of course, it would be better with 1.8, but that's fine. But let's say if it's higher than 4, then definitely we would come to Marat to refer to the extracorporeal methods. Next question: can ezetimibe be taken if cholesterol is increased 5.9, lipids normal, and patient with transplanted kidney? Asiat, what do you think? You love combined treatment. So please tell us what to do. As far as I understand, that's a mono treatment of ezetimibe, and definitely we have to say that we are guided by GFR. And this question has already been asked before. We didn't have time to answer. So we are guided not by the main disease, we are guided by the ALT and AST in patients with transplanted kidney, how it influences GFR. In the situation when we work with reduced GFR, the drug of choice from basic hyperlipidemic treatment is atorvastatin. And from clinical task, it is not quite clear there were any attempts of titration of different statins before. Why a patient is on ezetimibe as a mono? The answer would be guided by GFR. Thank you very much. Next question. Well, I think we can skip it. We already answered that. Patient has cholesterol 6.8, LDL 5.6, 3 months of ezetimibe with atorvastatin, no effect. She reduced weight by 30 kilos for 1 year, stringent diet from 83 to 59 kilos. Well, that's not exactly 30 kilos, but let's say the question is what to do, because hypolipidemic treatment is not effective. Marat, what do you think? Depends on the category of risk, but this is at least high risk. So we need to resolve the issue how to provide targeted treatments. That means PCSK9 inhibitors. Yes, right. Yes, right. We need to understand which category to go. That's an interesting question. Can male get hypocholesterolemic and antihypertensive treatment if pregnancy is planned? Asiat, this question is to you. Can we administer it to males? We cannot hear you. You are muted. She's nodding. That means yes, but we want to get the answer. That's very preferable. Something with your microphone, Asiat. We lost your microphone. Well, I think we should answer because Asiat, we cannot hear you. For the preconceptional period, for 1 month, maybe it's the best to refuse. That's not terrible if for 1 month the male is not taking. And what about antihypertensive? Antihypertensive, no, we should continue. We cannot stop that because he cannot survive until happy moment of conception, and the situation is not funny. Well, I never heard such recommendations that it's somehow limited for the patients, because we have very many elderly males who have still fertile females, fertile wives, and they are interested in that. So no, we should not stop. We should not stop that. There is no such data that it could lead potentially to the pathology of the fetus. No fetal pathologies, but I can provide my position if you schedule that. But this is not real life situation, because normally it happens spontaneously. It's not just, well, we decided and we do the conception. But I totally agree. Yes, we can stop. We can stop the treatment. And 1 year he was trying to get the pregnancy, and then there would be acute coronary syndrome, and the husband is dead, and the child would be father free. So lonely mother, no, not acceptable. With hypercholesterolemia, can we administer hormonal replacement therapy? Well, if you need it, you can. If you need it, you can. Well, I think the question about female sex hormones, well, they should be discussed very rarely in cardiology, because this is a way to know where. This is a way to know where. So it's better not to use them. The risk is increased 3 times. But 1 pulmonary artery thromboembolia would be very dangerous. So that's dangerous. In the normal levels of lipidograms in duplex brachycephaly, there is a plaque, and hypothyroidism and obesity grade 1. What should be the tactics besides diet and physical exercise? Well, if the plaque is more than 25%, then we should initiate statins, but in parallel, it should be control of thyroidal function. Okay, good. Can you hear me now? Oh, yes, yes, we can hear you at last. So continuation. So this is a small recommendation. When we assess lipidogram and it looks like normal for the risk that patient is in, then LPA small, lipo-A small, when we see the progression of atherosclerosis in the normal levels of LDL, probably this is lipo-A small, and that matters. Are there any fixed forms of statin plus ezetimibe? What is the brand? This is Rosuli Plus. This is Xenon. Rosucar Plus, Roxera Plus, and colleagues, atorvastatin, Carvazin Plus. Yes, Carvazin Plus. You're right. You're right. So any experience? Yes, we are using actively, and the results is really good. And we will show you later on. Next question, patient age 54, BMI 20, very low, no smoking, no risk factors, active physical exercise, cholesterol total 6, LDL looks like 3. Yes, looks like 3. Ultrasound of brachycephaly, plaque is 25%. Can we administer ezetimibe 10 milligram daily? Yes, I think yes. Yes, of course. But why we skip statins? Because sometimes we get this question. So I have a feeling, so it's an attempt to avoid baseline treatment, to avoid statins. Oh, yes, yes, yes. I see that very frequently, especially from endocrinologists. Well, I would not administer statin to such a woman. You know, reduce BMI 20. She has no other risk factors. Maybe she doesn't need statins. Well, 25% plaque. Probably we have to double check. I would interpret it towards de-escalation. But let's put it this way. This female could be followed up actively without medical treatment. Yes, yes, and because we shouldn't administer to everyone. Well, question 25 is not clear. Familial hypercholesterolemia, post-infarct MI, stenosis of carotids ezetimibe, waiting for averocumab, and TG is 5.4, and total cholesterol 14, LDL 8. Well, I think you should not wait. You should facilitate the supply. But this is not classical familial, so TG 5.4, but we cannot discuss it. We cannot discuss the case. Yes. Next question. Well, we skipped question 4, I think, about hypolipidemic treatment in the liver pathology, but they didn't explain why. Ezetimibe influences less to liver, so lower doses of statins, and if there is increase of 3 times, yes, of course, you should do it. Next question about the young girl, aged 18, LDL 4.9, no atherosclerosis, no risk, no family history, just follow. Yes, colleagues, important aspect here about all these cases. If this is primary assessment of lipidogram, so in any case, in doubtful situation, it's better to redo lipids within 4 to 6 months, especially after non-medical correction, possible non-medical correction. And if we confirm this lipidemia, then we can take decisions towards nutriceptics, but nutriceptics, they are not officially registered in the Russian Federation, but I saw in the list these questions about the treatments which are registered as biological additives, although they are not receptics. But answering your question, yes, we follow and we redo lipidogram within 4 to 6 months. And in case of liver pathology, we have to emphasize that only acute and active hepatitis is contraindication for hypolipidemic treatment. And final question by now. Patient 30 to 35 years. Yes, again and again, they want us to initiate the treatment. Patient age 30 to 35 years, total cholesterol 7, LDL 4. What should be the tactics to start or not to start? My position, I already emphasized, and I said, no, we follow. Well, if you don't mind, I will wave the white flag in between, white flag, and I would start. Well, dear colleagues, we have a chart, very good chart, which is a traffic light, green, yellow, and red. We speak a lot about it, but dear colleagues, they refer us to LDL, only to LDL, but it's very important. What is the risk of the patient? What is the risk of the patient? Keeping in mind cardiovascular risk and keeping in mind LDL. So we have 3 minutes. That's a very long answer. So we have some more questions. The patient in the red zone, so the drug treatment is not a must, But if somebody wants to start, you can start. No, the yellow is from age of 40, but the patient is 34, but still he is in the yellow zone. In the yellow zone, he's not in the white, not in the green. No, not in the white, not in the green, but not in the black, not in the red. Definitely, yes. Can you see next question? Question 29 and 30. Yes, patient has 100, 110, 130 tactics of hypertensive, nothing. That's normal blood pressure. Question 30, young female, age 35, LDL 3.5, cholesterol 5, LDL 2, obesity, hypertension, plaque 25%. What would be the stage, 1 or 2? And what should be the tactics of management? Stage 2, and the tactics, well, normalization of blood pressure, first of all. And I think we may not administer hypolipidemic. Yes, that was similar case, but antihypertensive, they should be there, should reduce weight, lose weight, you should lose weight. Well, thank you very much. It looks like we have no more questions and we're right on time. Yes, we're right on time. I would like to thank all of you. So that was a great pleasure to talk to colleagues and also to those who provided questions, comments and remarks. Thank you very much for your interaction. Thank you very much and hope seeing you again. Have a good day and goodbye.